there, ma'am, Ludhiana में.
अच्छा अच्छा, वो आप मैं
Pradipta.
मिस कर
Yes,
गई
yes.
एक्चुअली. हाँ
Yes,
राइट.
yes. I heard. Yes, ma'am. I think yeah.
कविता हमें भी बुलाओ.
आप तो कभी भी वेलकम मैम. आप
अब
बोलो,
आजकल
मैं उस दिन अरेंज कर
आप
दूंगी.
लुधियाना में
मैम आप डेट्स बताइए, हम तैयार हैं
Yeah.
आपको होस्ट करने के लिए एनी डे.
अरे वुलन खरीदने आ जाए, जाड़े आ रहे हैं ना.
That should be non-academic visit.
नॉन एकेडमिक, नॉट
सब
एकेडमिक.
इकट्ठा करा देंगे आपका.
Very good afternoon, all. We are live now on YouTube. So, from Corona Remedies, I would like to welcome all the Association of Maharashtra Gynec and Op Society, along with AMOGS Sexual Medicine Committee, who organizes this webinar in association with Punjab and Northern India Ops and Gynec Societies. So, from today's, the main conveyors are Dr. Madan Kamble, Dr. Purba Datta, and Dr. Prerna. So I would like to first introduce Dr. Madan Kamble to all of you. So Dr. Madan Kamble is the chairperson of the AMOGS Sexual Medicine Committee, National Coordinator, and also of Foxy Sexual Health and STI Committee. We welcome you, Dr. Madan Kamble. Also, I would like to introduce Dr. Apurba Datta to all of you, who is the chairperson of Foxy Sexual Health and STI Committee. From Corona Remedies, we welcome you, Dr. Arbuda Datta, Apurba Datta. And last but not the least, Dr. Prerna Kishan, who is a consultant gynecologic infertility specialist and endoscopic surgeon. She is like invited as a speaker at overall 300 zonal, national and international conferences and has many national and international publications. We welcome you, Dr. Prerna Kishan. I would request now Dr. Madan Kamble to start with the prayer.
Thank you, Mr. Prerak.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्युर्मामृतं गमय. ॐ शान्ति शान्ति शान्ति.
Thank you, Mr. Prerak. On behalf of AMOGS, that is Association of Maharashtra Obstetric and Gynecological Societies, and we have organized this special webinar along with the Punjab all Obstetric and Gynec Societies and Northern India, covering all the societies in Punjab, Amritsar, Bhatinda, Faridkot, Firozpur, Jalandhar, Ludhiana, Kotakpura, Nabha, Chandigarh, Patiala, Pathankot, and Kapurthala. We have covered almost all the societies, and thank you so much all the office bearers of all the societies for connecting with AMOGS and for accepting our invitation for this special webinar. With the blessings of AMOGS office bearers, Dr. Kiran Kurtkodi sir, who is the president of AMOGS, and Bipin Pandit sir, who is the honorary secretary of AMOGS, we welcome all the faculties, all the chief guests. Our chief guest today's chief guest is Dr. Professor Dr. Alka Kriplani ma'am, who is the past president of Foxy. I think ma'am is busy; she has not joined yet. Whenever she joins, we can have her blessings. We have guest of honors, Dr. Kiran Kurtukoti sir, who is the president of AMOGS, Dr. Preeti Kumar ma'am, Vice President elect North Zone Foxy, and Dr. Arvind Sharma, who is the senior obstetrician and gynecologist at Bhatinda. Kiran sir will join late. We can have a CV of Preeti ma'am. Yeah, I welcome ma'am. Ma'am is the professor and head at Medical College at Kanpur. She was the chairperson, Maternal and Perinatal Committee, Suffolk, and Vice President North Zone elect Foxy 2026. And currently, ma'am is the president of Lucknow OBGYN Society. Ma'am is very dashing, dynamic, and hardcore Foxyian. I'm very happy to actually had an opportunity to meet ma'am at Lucknow. It was a wonderful experience. I welcome ma'am, and I request you for your blessings. Over to you,
Thank
ma'am.
you, madam. Thank you so much. First and foremost, let me thank the AMOGS led by Dr. Kiran Kirtkoti and Dr. Bipin. And of course, the committee chair, Dr. Madan Kamble, for inviting me to this prestigious platform. And You have collaborated today with Punjab, with OBGYN Society. Madan, I must tell you that people from Punjab are very loving. So I have a very close association with everyone who has joined today. Dr. Kavita, Dr. Ginni, Dr. Nishi, everybody. I can see many other people. So they are very loving, and the topic that you have taken today regarding you are working very hard. And first and foremost, I must compliment Apurva, because I've seen him working for last 3 years before he became the committee chair. He worked very hard with Neeraj, and Neeraj has also done a good work in this field of sexual medicine. And you are trying to take this legacy forward, Madan. I'm very happy that you are following the footsteps of Neeraj and Apurva, and hopefully you will take this flag of sexual medicine ahead. And we need a lot of awareness regarding this sexual medicine and the sexuality, because this was till date a most neglected segment in OBGYN. And it's a great honor when you share the dice with legends like Dr. Alka Kriplani ji, who is the chief guest today. And I wish she would have joined today. I could have met her virtually. And Dr. Arvind Sharma, the guest of honor from Bhatinda. Thank you so much for being here. And the three conveners for today's event, Dr. Apurva, Madan, and Prerna, all of you are very, very hardworking and future of Foxy. So I wish you all the best for this program. Keep doing this awareness and spreading all the knowledge regarding the sexual medicine and the topics which you have taken today, the sexuality at menopause, pelvic floor dysfunction, and then the panel on female sexual dysfunction. I will try to stay back as far as possible, because I have some work pending for my Tripura mission that is scheduled on 5th and 6th November. So all the best, Madan, and wish you all the best for your elections also, because you are truly working very hard in this field for last so many years, and I'm sure that you would be a great future for this committee in Foxy as well. So thank you so much for inviting me and giving this platform, and wish you good luck for your the program webinar today.
Thank you so much, ma'am, your kind blessings and kind words, which means a lot for us actually. And thank you for joining with us today. I would like to thank and welcome my co-conveners, Dr. Apurva Datta, who is my very good friend, guide also, and my dear friend, Dr. Prerna Keshan, who is from Tinsukia. She's doing very good work in YTP committee of Foxy. And both of we are going for elections, for the chairperson elections, Dr. Prerna and myself. I welcome today's speakers, Dr. Kavita Bhatti ma'am, chairpersons Dr. Manjeet Singh Sidhu sir, Dr. Jagjit Singh, Dr. Nishi Gab ma'am, Dr. Mohini Agarwal, who is the next speaker, and the chairperson for the session will be Dr. Prerna Saigal ma'am, Dr. Gini Gupta ma'am, Dr. Sangeeta Pahwa, and all the panelists for the panel on female sexual dysfunctions, and also the expert Dr. Neelam Sodhi ma'am. I welcome all the faculties for today's session. Thank you so much again for joining, and thank you Preeti ma'am for coming for this program. Now we will move forward to the scientific program. Apurva, are you there? Dr. Apurva? Okay, over to you, Prerna. You can start the session number 1.
Yeah. I am very much there. I'm extremely
कुछ
sorry.
बोलो, 2 मिनट बोलो
Yes,
कुछ.
yes. First of all, thank you so much to all the societies of Punjab for joining in this really unique. Why I always say it's a unique, because our medical education, primary education, doesn't have any knowledge how to identify and how to treat these type of patients. And in our OPD day in, day out, we are getting these type of patients. So during Dr. Neeraj Jadhav sir, when he was the chairperson and I am the national coordinator, actually it's our effort that we reach each and every society of obs and gynae to give the basic knowledge of how to identify and treat this. And I am so happy that Madan sir is continue with that. And thank you so much. We have a very, and I am eagerly waiting to listen from all the lectures from Kavita ma'am and others. And all the very best, Madan sir and Prerna, both of them are my very good friends and my chaddi buddy. So thank you so much. And I request all of you, please support Madan sir and Prerna. So thank you so much, sir, Madan sir, to have me today. And definitely I am here till the last. So over to you, Madan sir.
Yeah. Thank you, Apurva. Thank you. Yeah, Prerna.
Wishing you all a very good afternoon, and I'm immensely honored to be part of this wonderful scientific session today. And thank you, Dr. Madan, for giving me this opportunity to share this platform with you. And I extend my heartiest regards to Association of Maharashtra OBGYN Societies for giving us this opportunity, and in association with all the Punjab and Northern India OBGYN Societies, to conduct this particular CME with the AMOGS Sexual Medicine Committee. And I extend my heartfelt regards to Dr. Kiran sir, Dr. Pipin sir, Alka ma'am, our chief guest today, and my very beloved Preeti ma'am, and Arvind sir from Bhatinda, and also our speakers and all our respected chairpersons, my co-convener Dr. Apurva and Dr. Madan, and all our respected panelists and everyone who has joined in today. And it gives us real pleasure, as Dr. Apurva has already mentioned, that the curriculum of our particular syllabus, it doesn't include anything like sexual medicine. So we need to reevaluate and reinvent the entire scenario and give this particular important topic a lot of emphasis, which is less talked about. I thank everyone for your blessings and keeping us in your hearts. Thank you, and hope we have a great session ahead. Dr. Madan, can we start with the scientific program?
Yes.
So
Mr. Prerna,
yes.
share screen.
For the first session, I'd like to invite our respected speaker, Dr. Kavita Bhatti ma'am. Dr. Kavita Bhatti ma'am, she has the professor and head of the Department of OBGYN CMC Ludhiana. Ma'am has a fellowship in reproductive medicine, and she has affiliations from the Ludhiana OBGYN Society, and she is one of the most beloved faces I know in PEG-FOXY, and ma'am has numerous awards and honors to her credit. We welcome you, ma'am, to this prestigious platform, and we are all eager to hear you. For chairing this session, we have Dr. Manjeet Singh Sidhu, President from Bhatinda Society. And sir has over 30 years of experience in operative gynecology, and he is a pioneer in NDVH in North India since 1997. Next, we have a chairperson, Dr. Jagjit Singh, sir, who is a secretary of Faridkot Society. And sir has a lot of professional roles in our FOXY, as well as in the Special Doctors Association of Punjab. And he has special interest in National Health Program implementations and quality improvement in healthcare. We welcome you, sir. And we have a third chairperson, Dr. Nishi Garg, very charming personality. And she's a director of Garg Multi-Speciality Hospital from Faridkot. And she has more than 34 years of experience in gynae ops and the president of KFOG Society. Now, we welcome you, ma'am, to this esteemed session. And I hand it over to you to invite our speaker for the prestigious talk. Over to you, sir.
So should I welcome her?
Yes, please.
So
I think you've already introduced Dr. Nishi without
but
wasting
Dr.
time.
Kavita doesn't need any introduction. So
No, I need a lot of introduction, but I've already been introduced by Dr.
yes,
Prerna.
so eager to listen from you everything. Welcome you.
Thank you so much. And at the outset, I would like to thank AMOGS, all the office bearers of AMOGS, and the coordinators for today's event, Dr. Madan, Dr. Prerna, and Dr. Apurva, for giving me this opportunity and making me read a topic after almost 10 years, because it was 10 years before when I was doing my reproductive medicine fellowship at CMC Vellore. We used to read about this topic. And as discussed earlier, this topic we don't speak much about, and we don't address these issues in our day-to-day practice. So thank you for that. It is always nice to associate with all the societies of Punjab. So Faridkot, Pathankot, and Amritsar, Jalandhar, Ludhiana, as I'm a member of Ludhiana OBS and Gynae Society. But let me tell you, this is my second home. My first home is Maharashtra and UP. Maharashtra because I was born at Pune and I did my schooling in UP. So it is very nice to associate with all the societies. So let me share my screen, PPT, and I hope it is visible. Can you see the screen?
No, ma'am, you have not shared yet, sir.
Now?
Yes, it's visible.
Okay, so I will be speaking on sexuality at menopause. So we all know that menopause is a transitional time in a woman's lifetime, which is characterized by hormonal changes, physical changes, psychological changes, and also social changes. But because of the age-related decline in the sexual steroids, which are secreted by the body, there is also a decline in the sexual function, which may have a significant impact on her quality of life. So we need to talk to our menopausal ladies about sexuality because it is a very important component in the lives of our women. Little bit about sexual desire. So this is actually because of the action of the various neurotransmitters which are secreted from the brain. And those which lead to sexual excitation are dopamine, melanocortin, oxytocin, vasopressin, and norepinephrine. Opioids, serotonin, endocannabinoid, and prolactin are supposed to decrease sexual desire. But one should always remember that the interplay of all these neurotransmitters either lead to good sexual function or a sexual dysfunction. Also, any experience in the past and behavior may alter the function of the brain as regards to sexual health. There have been various studies which have considered attitude about sex at menopause. The first, which was published, was a SWAN study. That was a study of women's health across nation. And it was a survey which was done in the middle-aged women, where 76% of these women reported that the importance of sex, it was either moderate or extremely important to them. There was another survey, Women's Healthy Aging Project, and this was carried out in postmenopausal women, either early postmenopausal or late menopausal women. And this found out that there was a significant decline from 74 to 56% in sexual activity, and this was statistically significant. There was another extension of this same project, short personal experience questionnaire survey, where the scores indicated that 42% of early perimenopausal women had sexual dysfunction. And when they surveyed again after 8 years, they found that sexual dysfunction had actually doubled up to 88%, according to this score. So we see that this problem is quite prevalent in the perimenopause as well as the postmenopausal ladies. Now let us look at some of the factors which affect sexual health at menopause. We all know that menopause is associated with hypogonadism and hypergonadotrophism, where there is low estrogen levels, which may adversely affect sexual interest and responsiveness, and also affects the elasticity of vaginal mucosa. It leads to reduced vaginal secretions, vaginal atrophy, and also atrophy of the vulva, leading to pain during sexual intercourse, which may again interfere with sexual function. Other factors include pelvic floor weakening, which is basically due to tissue degradation, pelvic denervation, and devascularization. All this may lead to dyspareunia, chronic pelvic pain, and also a modified self-image. There are associated psychosocial factors and social stressors or life stressors such as divorce, lack of a partner, job loss, or declining health during this phase of the women's life, which may again have a bearing on the sexual health. There are some of factors which are modifiable. So this includes medical conditions like chronic diseases, hypertension, diabetes, depression, neurological diseases, incontinence, which is quite prevalent in this phase, obesity, osteoarthritis, and also vascular disease. Medications like serotonin reuptake inhibitors, neuroleptics, cardiovascular medications, because with advancing age, they are more prone to develop chronic diseases and therefore more on medications. Therefore, these medications may also alter sexual function. These factors have been classified into predisposing factors, precipitating, and maintaining factors. So again, biological problems like gynecological interventions or a surgical intervention earlier, the timing of menopause, and also psychosexual problems like personality traits, history of sexual abuse previously, or domestic violence, any personality disorders relating to coping strategies, or contextual disorders like ethnic, cultural, and other factors may also be involved. Precipitating again are those related to psychosexual and biological again, which mainly depends upon the extent and severity of menopausal symptoms and iatrogenic menopause if there is a previous surgery where the ovaries have been removed, psychosexual because of loss of partners and other life stressors. Maintaining factors are those which include perception of menopause changes because the patient may have altered perception, loss of sexual confidence, and also related to the partner's general health or sexual problems, and lack of access also to the healthcare facilities. Now, this is a quality of life in menopause symptom domains chart, where they have emphasized that besides the physical, psychosocial, vasomotor domains which affect the life quality, sexual health also plays a negative impact if there is any dysfunctions associated. Now, there are certain barriers which needs to be addressed before we talk about sexuality at menopause with our patients. Some of them are the cultural biases. There is always a stigmatization of women as being asexual as age advances, or because we always consider that aging is an inevitable process, and in that sexual health also goes down, which is actually normal for many, considered by the women or by the healthcare provider. So it is a bi-directional process where you take it as a norm that sexuality, there is loss of sexuality after menopause. Then there's another factor, which is individual sensibility. It is because of embarrassment or because the patient considers as a very intimate topic and does not want to open up with a healthcare provider. Also, there may be some unawareness or poor confidence, and they do not want to really disclose or take any treatment for such problems. Now, how to approach this has been addressed by the International Society for the Study of Women's Sexual Health, and they have actually proposed a process of care where you start with a conversation with the lady around this topic. And this society has provided a simple framework for effective screening, management, and referral for any sexual dysfunction during menopause. So this has there is a 4-step model for sexual assessment according to this international society. The first step is universal screening. So here you are giving permission to the women to express her sexual symptoms or concerns. So that comes as P. The second step is you offer her information. That is O. You give her information about how menopause can affect her sexuality and also cause a negative impact on her health quality or life quality. Third is you suggest any remedial measures which may be very elementary, like providing lubricants, moisturizers, or counseling them, giving them marital counseling, or counseling addressing other health issues. And the fourth step is when you refer them for intensive therapy, provide them with higher pharmacological treatments, sex therapy, and physical therapy. So this is an algorithm which is provided by this international society where you have to actually screen them and group them into 3 categories. One is those with low sexual desire. Second may be those with no sexual concerns. And the third is when they have other sexual concerns besides low sexual desire. So basically, this algorithm is to detect or manage hypoactive sexual desire disorders in women. So here you have to diagnose by decreased sexual desire screening. And also when you find them that they are affected by this and they need treatment, then you also focus on medical assessment to identify any biopsychological factors which may be causing this disorder of hypoactive sexual disorder, and then provide therapeutic intervention. So what is this decreased sexual desire screener? So if you see on the right side, there is a chart which has at least 5 questions and 7 sub-questions to the 5th one. So this is a validated instrument for confirming the diagnosis of generalized acquired hyperactive sexual dysfunction. And it is very user-friendly. I think all of us should keep it in the outpatient department and screen our ladies for any sexual dysfunctions. It encourages and gives permission to the healthcare provider as well as the menopausal women to open up the conversation around sexuality. So again, looking at the 4 questions that have been put up in this screener, the first is if they've had any sexual desire in the past, whether it was good and satisfying. Has there been a decrease in the level of sexual desire is the second question. Are they really bothered by any of these symptoms or decreased level of sexual desire? And the fourth question is, would they like the level of sexual desire to be improved? So if the woman responds no to at least one of the first questions, she does not meet the criteria for generalized acquired hypoactive disorder. And if the patient answers yes to questions 1 through 4 and no to all the factors in question 5. So if you see the 5th question has 7 subsets and basically involves questions regarding physical ailments or previous surgeries, medications, pregnancy, recent childbirth, and also addressing sexual problems in the partners. So if the patient answers yes to questions 1 to 4 and no to all the factors in question 5, then she has generalized acquired hypoactive sexual dysfunction. So this is a useful tool for determining whether they're really suffering from sexual dysfunction. It is an objective tool. So when we are addressing this problem in the menopausal ladies, one should consider any biopsychosocial determinants of sexual function. So if you see the biological factors which are involved, which I've already spoken about previously, where you take a detailed history of menstrual dysfunction, if there's any gynecological problems like incontinence, any history of cancer, whether she's getting treatment for cancer like a chemotherapy, radiotherapy, any metabolic problems, neurological problems. Psychological would be anything related to poor self-esteem, negative body image, mood disorders, and personality traits, past sexual experiences. Socio-cultural, basically regarding gender equality issues, if there is any work pressure, environmental factors, cultural factors, and social support, also access to care. Relational factors may be absence, loss of partner, communication with the partner when there is relationship problems, then all these factors should be addressed while you're interviewing the lady for any sexual dysfunction during menopause. So a detailed gynecological history is very important, where you consider all these ailments, because this can also lead to sexual dysfunction. Physical examination is as important as the history. So you look for conditions like clitoral adhesions, phimosis, which are common in this age group, urethral prolapse, vulvodynia, again a very common problem. So this can be assessed by applying pressure with cotton swab around the vestibule, starting from 1 o'clock to 11 o'clock position, and look for any pelvic floor dysfunction, look for labial atrophy, vaginal atrophy, vulvar dystrophies, any pudendal nerve disorders, and other spinal pathologies. So all this examination is very important when you're considering sexual dysfunction. Sometimes we need to do blood tests for determining any other health-related issues which may be causing loss of sexual desire, such as you do a serum prolactin, thyroid function panel test. Hormones like estradiol, progesterone, LH, FSH, testosterone, and sex hormone binding globulin can also be tested for. Do not forget to do the assessment of the menopausal status, because again, this has a bearing on the sexual dysfunction. So whether she's in the premenopausal phase or in the menopausal transition or the postmenopausal phase. So we use the straw method of stages of reproductive aging workshop classification system. Coming to the disorders of sexual dysfunction, I'm going to talk about two very prevalent disorders in the menopausal ladies. The first is the hypoactive sexual desire disorder, which I've already spoken about, how to diagnose and use the algorithm and the screener. And the next is the genitourinary syndrome of menopause. So this HSDD definition has been given by the International Society, where it says that if the lady presents with any of these three symptoms for a minimum period of 6 months, what are these symptoms? Decreased or absent spontaneous desire, and decreased or absent responsive desire to erotic cues and stimulation, or if there is a loss of desire to initiate or participate in sexual activity. She may be avoiding certain situations that could lead to sexual activity. Along with this, she has clinically significant personal distress, which may include frustration, grief, guilt, incompetence, feeling of loss, sadness, sorrow, or worry. So the diagnosis of HSDD should be made only after you exclude any organic or iatrogenic causes. It has been seen that the risk for HSDD is greater in those who have undergone surgical menopause, prevalence being between 14 to 33%, and it may be lifelong, acquired, and generalized or situational. So we have already spoken about the self-administered validated questionnaire, such as a decreased sexual desire screener. Rule out other factors like conflicts with the partner, history or sexual abuse, and cultural and religious factors. Genitourinary syndrome is also very prevalent in the menopausal clinics. So this is basically an overlap of urinary symptoms, sexual symptoms, and genital symptoms. Urinary being urgency, dysuria, nocturia, incontinence, recurrent UTIs, sexual related to painful coitus, dyspareunia, decreased lubrication, arousal, and decreased or delayed orgasm, and also vulvovaginal dryness, burning, irritation, or itching, which leads to genital symptoms. So again, history and pelvic examination are the cornerstone of diagnosis for vulvovaginal atrophy, which leads to GSM, that is genitourinary syndrome of menopause. Examination again is very important, where you see the labia majora and minora shrunken, and a smaller introital opening, thinning and pallor of the mucosa, loss of elasticity, and presence of petechiae, which may bleed on light contact. You can also diagnose GCM by an objective assessment of vaginal atrophy. So some certain clinical tools have been used, and moreover, more in research than in a practical this thing, because GSM is a diagnosis of history and examination. But just to mention, there are clinical tools also available like Vaginal Health Index, Vulvar Health Index, and these charts are available where you score. A score below 15 indicates vaginal atrophy. Also, Vaginal Maturation Index may help in diagnosing the GSM, because we see that in the postmenopausal ladies, the superficial and the intermediate cells go down, the parabasal and the basal cells increase in percentage. So if the score of vaginal maturation index is low, that is when it is less than 49, that is 0 to 49, then you think about GSM. So these are some tools which may help in the diagnosis. And this study was actually done, and Real Women's Views on Treatment Options for Menopausal Vaginal Changes Revive study. So in this, 63% women with vulvovaginal atrophy reported that the systems really interfered with sexual intercourse, and 47% of partnered women those who had partners, indicated that it interfered with their relationship. So this is just to show how GSM may affect sexual function. Coming to the treatment, there are certain non-pharmacological treatment options available, like psychological counseling. We know that it is very important. You have to address issues to relationships or sexual abstinence, sexual abuse history, lack of sleep, because all these can affect sexual function. Behavioral exercises can be employed to reduce anxiety, which is associated with sexual dysfunction again. So this is the first and second line treatments which are offered. First is the education, where you counsel them, then treat the gynecological disorders which may be present, like incontinence or any malignancies, cancers. And also you can offer them vaginal lubricants, moisturizers, low dose vaginal estrogen, or even intravaginal DHEA. Physical therapy and hormonal systemic therapy may be employed, but to a certain extent, but it has shown that it is not very effective. Coming to vaginal lubricants and moisturizers. Vaginal lubricants are those which are used before intercourse. So this gives a temporary relief from vaginal dryness and dyspareunia. And these can be either water and silicone based, and helps in the act of sexual intercourse. Moisturizers are those which mimic the natural secretions in an estrogenized vagina, independent of the timing of sexual activity. So these are basically hydrophilic, and they are bioadhesives and help in restoring the vaginal secretions. So therefore, some of these vaginal moisturizers and lubricants can be offered to these ladies who are having sexual dysfunction, especially related to GSM. Treatment options which are non-pharmacological are pelvic floor physiotherapy, and these are specialized forms of physical therapy to address dysfunction in the pelvic floor muscles, to treat pain, incontinence, and issues related to sexual function. So a physical therapist usually employs exercises to strengthen or relax the muscles of the perineum, and any other manual therapy, biofeedback, and other techniques which will improve bladder and bowel control and support the pelvic organs. Psychological factors and treatment strategies have been well defined. So basically, you need either pharmacotherapy, psychotherapy, or cognitive behavioral therapy for these issues. Hormonal replacement therapy. We all know that it is a treatment for vasomotor symptoms in a menopausal lady. So when you give systemic HRT, it may help with VMS, sleep disruption, fatigue, and can have some effect on the sexual function. But studies such as Cochrane review has seen that HRT, when given for sexual dysfunction, it has only small to moderate benefit. There was another study by Women's Health Initiative which showed that 74% of women still reported genital symptoms after 1 year of HRT. So systemic therapy approach is actually currently recommended only for, is not currently recommended for isolated GSM or for the treatment of sexual dysfunction, but it may help in other factors like sleep disruption or the general feeling of well-being. So it may have an indirect effect on sexual function. Third line treatment options are sex therapy, which again includes behavioral therapy, cognitive behavior therapy, and mindfulness therapy. There are certain CNS agents which are available, and flibanserin is currently the drug which has been used for generalized acquired HSDD in premenopausal women. And there have been clinical trials in postmenopausal women. They have found similar efficacy, but it's not currently FDA approved. So the dose is 100 milligram at bedtime, and this is supposed to decrease certain neurotransmitters which will help in sexual desire. So it has been seen that 50% of women with HSDD respond to this drug, and it may take up to 8 weeks for the effects to come. Adverse events are dizziness, somnolence, nausea, and fatigue. Testosterone has also been used, especially the transdermal administration, where you use 300 micrograms of transdermal testosterone patch. Significant benefits are seen only after 4 to 16 weeks of therapy, and always consider stopping the treatment if you do not see any improvement after 6 months of therapy. There may be certain side effects like mild hypoandrogenism, and Tibolone has been also used, but there is no definite evidence to confirm benefit on sexual desire in postmenopausal women. There have been some RCTs which found Tibolone to be marginally effective because it has weakly androgenic effects and therefore increase an endogenous free testosterone because it lowers the sex hormone binding globulin. Then DHA can be used as an intravaginal for intravaginal administration. It has been approved by FDA and it comes as the name of prasterone. Systemic treatment with DHA is not effective in improving desire and sexual dysfunction, especially in postmenopausal women who have normal adrenal function. These are the prescription medications which have been advised for GSM or vulvovaginal atrophy, local estrogen therapy, which comes in various formulations. There can be tablets or gels, pessaries, creams. Prasterone, that is the intravaginal pessary of DHEA, 6.5 milligram, and ospemifene, again oral tablets, 60 milligram. Daily use can also relieve moderate to severe GSM symptoms. So this is the hormonal interventions chart, which have been approved as treatment for GSM by the American Urological Association. And this came out very recently in 2024, where they have described all the estrogen therapy creams and inserts, rings, which can be either administered or taken orally as ospemifene 60 milligram per day. So the choice of agent depends on efficacy and adverse effects, the preference of the patient and accessibility, and also whether she can use it consistently. Local estrogen therapy, we all know Premarin in estriol creams, which are available, and they can also improve sexual genital arousal and orgasmic function. Prasterone, we have already spoken about. There's another drug, bremelanotide. This is a melanocortin agonist, which stimulates dopamine. It is given as subcutaneous injections, 1.75 milligrams. It increases sexual desire and decreases sexual distress, but has some side effects like nausea, headache, vomiting, fatigue, hot flush. Approved in US. I'm not sure whether it is available in India. Our experts may be able to tell, but I have not ever used it. I have no experience on this. Newer drugs like Lorexis is an oral non-hormonal medication, which again affects the neurotransmitters. Sublingual sildenafil and antidepressants have also been tried along with combination of testosterone. Other newer drugs are also available like tissue selective estrogen complex, conjugated estrogen combined with bazodoxifene, which improves VMS, vasomotor symptoms, and atrophy. But the risk of venous thromboembolism and stroke is high. Physical therapies are pelvic floor muscle rehabilitation, rejuvenation, and laser therapy. So we always wonder because this group of patients are always like most of them, they have some cancer related issues. So I was looking through the literature and found that there was actually absence of evidence which links low dose vaginal estrogens to the development of breast cancer. And local low dose vaginal estrogen does not increase the risk of either primary breast cancer or recurrence of breast cancer. So it can be safely given in survivors with GSM. Breast and endometrial cancer, again, vaginal DHA, neither vaginal DHA nor ospemifene increase the risk for breast cancer. And local low dose vaginal estrogen does not increase risk for endometrial hyperplasia or endometrial cancer. And the same is for vaginal DHA and ospemifene. So these are some of the safer options. This is a flow chart for the management of sexual dysfunction in menopause, where the first line approach is to address the modifiable factors, non-pharmacological intervention, sexual education, and also involve the partner, which is very important. If there are mild symptoms, no contraindications to hormonal therapy, that you can give accordingly, vaginal lubricants or psychological interventions for HSD, depending upon the problem that the patient is actually having. Pelvic floor physiotherapy also can be given for mild symptoms, and dilators may be used. Moderate to severe symptoms not responding to non-hormonal therapy, you need to give local hormonal therapy or transdermal testosterone, intravaginal DHEA, local estrogen. So you go like a stepwise. If there is moderate to severe dyspareunia, which is not being treated by local estrogens, then you can switch to oral ospemifene and oral conjugated estrogen and bendazopyfene. This is just a hypothesis in women with HSD. This is one of my last slides, that whatever treatment you offer, whether it is a sex therapy, central nervous system agents, or hormonal agents, the ultimate response is on the brain function and the neurotransmitters that regulate the sexual desire. So basically, the inhibition of sexual desire is suppressed and excitation is increased. So to conclude, sexual health and function are really important components in care of our menopausal women. One should openly talk about this in our daily practice because many of our women suffer from this silently. The healthcare professionals should be proactive and routinely screen perimenopausal, menopausal women for sexual dysfunction and offer support and treatment options. Thank you very much.
Thank you, Kavita ma'am, for that extensively elaborate and informative talk. It was indeed a treat to the ears to hear you speak so well, and really, really a brilliant presentation, ma'am. Thank you so much for being there for us. And over to our chairpersons, Dr. Manjeet sir and Dr. Jagjit sir and Dr. Nishi, for your valuable inputs.
So definitely this was a very, very elaborate topic. And I think Dr. Kavita, you covered each and everything in this topic, starting from the incidence. It is true that in this age group, the incidence which is seen in the reports, it is much more because we are not asking this history in our day-to-day practice. So if we add like we are writing down personal history, family history, 2 lines about sexual history, if it is taken, I think we can diagnose more patients and we can help them with much more drugs and psychotherapy for that. So regarding drugs, lot many drugs are available. I also searched the net, these drugs like serotonin antagonist and the mineral corticoid, flibanserin, and these are newer drugs, but the literature says they are very effective in premenopausal women. So definitely with coming times and with coming history more, so we can help these patients more. Evalon cream or estrogen cream definitely is a best drug which we are using right and left for our patients. So in toto, it was a good talk. Thank you very much for enlightening us with this.
Thank you, Nishi ma'am. Dr. Manjeet has joined in. Sir, if your valuable input, sir. Dr.
Yeah,
Manjeet.
yes. Dr. Kavita has covered it very nicely. and she has told us all the things that we need to do for such patients. And a lot of these drugs, I don't think they are available, but it is nice. Then everyone now will be looking out for these drugs whenever they are available. And also, as Dr. Nishi has said, that we must take 1 minute off to take the history of such conditions so that we can treat them at the earliest point of time. That's it.
Thank you. Thank you, sir. Thank you. Thank you, Rishi ma'am. Thank you, Manjeet sir. And thank you, Dr. Kavita, for such a brilliant session. And we'll now move on to our next scientific session. I hand over to Dr. Vandan for the further proceedings.
Thank you, Kavita ma'am, for a wonderful talk. You have covered everything about the GSM in details. Thank you, Manjit sir, for joining us. Now, our second session is on pelvic floor dysfunction and sexual function. Mr. Prerak, can you display the slide? Our speaker is Dr. Mohini Agarwal, madam, from Bathinda. And we have got the chairperson for this session, Dr. Prerna Saigal, ma'am, Dr. Gini Gupta, ma'am, and Dr. Sangeeta Pahwa. Yes, next. Yeah. Dr. Mohini Agarwal, madam. Next slide. Next. Prerak. Yeah. Dr. Saigal, ma'am, with the secretary of Pathankot OBGYN Society, senior obstetrician gynecology practicing at Pathankot. Welcome, ma'am. Next.
Thank you.
Yeah. Gini Gupta, ma'am, who is the president of Ludhiana OBGYN Society, senior consultant at Ludhiana. Also member
Thank you,
of.
sir. Thank you. Thank you.
Thank you and welcome, ma'am. Dr. Sangeeta Pahwa, ma'am, who is the secretary of Amritsar OBGYN Society. She's also senior OBGYN practicing at Amritsar and also professor and head of the department at SGRD Medical College, Amritsar. Welcome all the chairpersons. And I request Dr. Gini ma'am to introduce and welcome Dr. Mohini Agarwal. Over to you, ma'am.
Thank you. First of all, thank you, sir, for organizing this lovely webinar on a topic which needs much deliberation. And thanks to all of you. This is making great headway, and we have so many people in our society who are already interested. Dr. Mohini, I welcome you to speak on the next topic of pelvic floor dysfunction affecting the sexual dysfunction. And she is a director and senior consultant urogynecology at Urogynecology and Pelvic Health Care Clinic, Bathinda. And she is also a fellow in urogynecology and pelvic reconstructive surgery from our AIMS, New Delhi, and has special interest in urogynac, menopause and geriatric health and pelvic pain. And she has contributions to so many. She has a YouTube channel, educational YouTube channel, and international national publications. So, well, without wasting much time, welcome, madam. And you are from our very own Bathinda also. So, we are waiting to hear you.
Thank you, ma'am. Thank you, everyone. First of all, I'd like to thank AMOGS and Dr. Madan sir and Dr. Manjit Sidhu sir for the wonderful opportunity. It's literally a pleasure to talk on this topic. As already सबने बोला है कि it's very less taught in our colleges PG times, but as a Urogyne, in and out I see, and it's so huge and vast topic. So I had just very a small section of it. Ki what the pelvic floor dysfunction due to the sexual function, and many of things is already covered by Dr. Kavita ma'am. So I just elaborate a very small segment of it, pelvic floor dysfunction and sexual function. So pelvic floor, it's made up of muscles, fascia, ligaments, which is at the base of the pelvis. It span literally from pubic bone at front to the tailbone in the back. These are the muscles from above, levator ani, obturator internus, and from below we have the perineal muscle, anal sphincter, superficial deep, ischio cavernosus, bulbospongiasis. I'm not going detail. So pelvic floor, what it is, it just not only means so pelvic floor dysfunction doesn't indicate or mean prolapse. Very first thing, again, it's a myth misnomer. Pelvic floor dysfunction doesn't mean that it's only prolapse. What the function it has a support to pelvic organ support. Yes, if the support is lost, then it presents as prolapse. Bladder and bowel control. If it is lost, then it presents as incontinence. Then it's passing of urine and feces. Sexual function is also majoritively supported by pelvis. Sexual, whenever we talk about any sex problem, it's first is the brain. So for brain, what I see, so seeing is very important. Sensation, feel is also very important when I take detailed history of the patient. So it comes the combination of the eyes, senses, what you feel, and the brain part, and then the last or the target organ is nothing but the pelvic floor muscles. So my topic, like, it's pelvic floor dysfunction. What happens when the pelvic floor function doesn't function properly? Pelvic floor functions synchronously with breathing, and it helps in pregnancy and childbirth. So this many functions is done by pelvic floor. So what is pelvic floor dysfunction? It is a collection of signs and symptoms affecting the pelvic floor, and incontinence is the most common one of the type of presentation of pelvic floor dysfunction. Sexual dysfunction is common in women with pelvic organ prolapse, regardless of the prolapse stage or the compartment affected. To explain this, many of them we can see the cases prolapse. We have all seen the prolapse in stage 1, 2, 3, and 4. Precedentia patient, difficult to redeposit it. If directly we go into stage 4 of prolapse, the patient may have dyspareunia for the very obvious reasons. Usually they are menopausal patient, they may have ulcers also. But if we go from the starting, like stage 0 also, there is no prolapse, but many of the time we have seen patient comes with the sensation of prolapse, something coming out or heaviness below there. But when we examine, there is no prolapse. So right from any of the stage of prolapse, when the complaint is of prolapse, again I repeat, when the patient complains of prolapse, but there is no prolapse, still patient has a sexual problem, and it's irrespective of compartment affected. Now in this, suppose if compartment anterior or the middle or the apical or the posterior one, any of the compartment affected, it will lead to sexual dysfunction. So prevalence of sexual dysfunction as such is 30 to 50%. With pelvic floor dysfunction, the incidence is as high as to 50 to 83%. And now this pelvic floor dysfunction ranges or affects the age group right from the teenager, which we have seen the many females or girls get active at very young age than it was previously. And nowadays, as the longevity is increased, even the menopausal patient, means earlier we used to see that in menopause patient, usually the sexual desire and activity as such in India also decreases. But nowadays we are seeing even the 60, 70 females are also sexually active, and they are concerned for their sexual problems. So pathophysiology, what has happened is the connective tissue is changed. So collagen, there is decrease in type 1, that is involved in tissue stiffness, and increase in type 3 collagen, that is involved in tissue elasticity. So the ratio gets altered. So abnormal biomechanical properties of pelvic floor, like avulsion during the pregnancy and the labor, even the pregnancy itself, even if the patient has undergone cesarean section, still there are pelvic floor dysfunction has happened. So postpartum pelvic floor rehabilitation is very important to prevent sexual dysfunction in the later stages of life. So what we can do is that, what basically I'm trying to say is that pelvic floor dysfunction can occur right from the teenage group till the late menopause also. The connective tissue may be get affected, fascia, collagen, and even the conception itself. As we see the nulliparous prolapse or the pregnancy itself has a huge burden on the pelvic floor. So we need to, whenever a patient comes, as already said in history, we should always ask the sexual history. And the same is whenever a patient comes, when we examine any patient, we need to see the pelvis as such or the perineum to be very specifically evaluated, because we can prevent. These are all the preventing things we can be done. And so the most important or the summary of my presentation, pelvic floor dysfunction. What are the pelvic floor dysfunction? It is dyspareunia, it's vulvodynia, vestibulodynia, vulva vestibulitis, vaginismus, levator ani syndrome, anismus, pudendal nerve entrapment, scar adhesions right from the below vagina. That also, and even the cesarean, previous cesarean scar also, that adhesions, interstitial cystitis, inflammatory cystitis, or the painful bladder syndrome, endometriosis that may also lead to pelvic floor dysfunction, trauma, post-traumatic stress disorder. So what exact cause is not known, the contributing factors. So pelvic floor dysfunction, it refers to both the type of pelvis. One is the normal pelvis and other two comes are the hypotonic pelvis or the hypertonic or overactive pelvic floor. And both type of pelvic floor leads to sexual problems. So we need to identify, like if a patient complains of orgasm, and one more important thing, in both type of pelvic dysfunction may coexist together in a single patient, not at the same time, maybe at different time. Yes, but the both type of pelvic floor may have. In some patient of Leber-Arana syndrome may have hypotonic urinary incontinence also. So hyper and hypo pelvic floor tone differ may occur in single patient. So that needs a detailed evaluation. And for the evaluation, I think the best way how to ask a sexual history is nothing but a questionnaire. If we see the most common one used, which we use is FSFI. So it's a huge questionnaire, and each symptom we'll see next in the panel also, that was the sexual model, how it goes, excitement, plateau, and then orgasm and resolution. So in each questionnaire, even the many times the patient comes, they even don't know what to say or what to tell. It takes literally a lot of courage for the patient also to speak up her urinary fecal problem, and for that matter more courage for speaking sexual problem. And that also मतलब वो शर्मा के बस एक ही शब्द बोल देती है, हाँ बस मेरे को ना मन नहीं करता. Now literally as a doctor, as a clinician, as a delivering skill to the society, we should elaborate each and every symptom in detail so that we can manage her better. So what the patient do? Usually restrict oneself. There is a fear of urinary incontinence, fecal incontinence for that matter. And when they're sexually active, both the partners, a female may have coital incontinence also. That is very embarrassing, and patient herself stop indulging in any sexual activity. Fear of image of vagina, as we are conscious for the body. Many patients have the fear, even not only at the perimenopause or menopausal age, right from the delivery, the patient has the fear that everything down there has been changed. So irrespective of the mode of management of the pelvic floor dysfunction, there is always a risk of de novo dyspareunia. Now in this, even if the pessary is used, as such pessary, they are proven and by clinical also that pessary does not cause dyspareunia. But yes, with the surgery also, there has been seen incidents that after surgery also there is a risk of, not always, the dyspareunia definitely decreases, but there is always a risk of de novo dyspareunia. Again, native tissue repair or transvaginal mesh. I'm talking about here transvaginal, not the sacrocolpopexy mesh. So in this, both of them, they have seen that native tissue repair has better sexual outcomes as compared to transvaginal mesh, especially in case of dyspareunia. So the prevalence of post-operative dyspareunia is lower than pre-operative dyspareunia in all type of surgery. This is done by the study. So total dyspareunia higher is always after transvaginal mesh if is used. And as it is said that when sacrocolpopexy is done, subtotal hysterectomy has better advantage for the mesh erosion and exposure, but it has nothing better advantage associated with sexual function. So most patients says in the study that the sexual partner, 74 have the sexual partner and 56 reports a recent sexual intercourse. But their study has been seen that there is a low level of sexual desire, enjoyment, and moderate levels of sexual arousal and orgasm. So pelvic organ prolapse, obstructive defecation, fecal incontinence, they are associated with not enjoying sex endurance and then non-sexually active ones. So women with pelvic floor dysfunction always have a large burden of sexual dysfunction, although this appears to be mediated by factors not unique to pelvic floor dysfunction. Just as case of menopause, at that age of time, there are various other things going on in the body, and at that transition of life, they also think personal also patient deals. So at menopause, obviously pelvic floor function differently, but there are other factors also add up to that. So whenever we treat a sexual symptom of any patient, it's always wholesome, and I think questionnaire helps the best to decide what's the problem the patient is suffering from. So frequency of sexual intercourse and orgasm may decrease with aging. A relationship between the sexual activity and pelvic floor muscle strengthening remains apparent once both sexually active women and those who have orgasm shows better pelvic floor muscle endurance than non-sexually active ones. This is the thing which I was telling. For patient to have better orgasm, when the patient comes with low orgasm, better orgasm, usually recommend pelvic floor strengthening exercises. But that patient may have both things. Suppose a Leber-Arana syndrome, when there is a constant contraction or tone of increased tone of Leber-Arana. And in that, if we go on teaching her or advise her to do Kegel or pelvic floor strengthening, it will worsen it. So we need to balance and modify what it is going on. Second, in case of like menopause, GSM patient, we need to treat that also. That may be the cause for loss of libido. So that's the thing. Cause is important or the symptom is important, what actually the patient is suffering. So in postpartum, there is again one interesting study which has been done postpartum leave. What they did that postpartum pelvic floor muscle strength and sexual function in primiparous women who have undergone uncomplicated vaginal delivery. It is significantly improved with the addition of sexually induced orgasm. It will like, as I said, orgasm when the pelvic floor muscles is contracted, strengthening. So they have advised them to do it, and it worked as good as Kegel exercises. So this was one study. So the pelvic floor dysfunction is a two type: underactive, that is weak, hypotonic or loose, which is prolapse, सब कुछ बाहर निकल रहा है, organs, pee, poo, urine, fecal, that is underactive pelvic floor. And one more, it is overactive, tight, hypotonic, spasm or short. It may have painful sex, hard to pee or poo, painful bladder, pelvic abdominal pain. And there are some set of patients which have overlap of this symptom, and it's the most difficult to treat. So physiotherapy is the first line of management when it comes to the pelvic floor dysfunction as a cause of sexual problems. Physiotherapy stretches and massage the pelvic floor with help of assistant of biofeedback, which play a wonderful role in it. Exercise for whole of the body to increase core strength, avoid heavy weightlifting exercise, avoid high impact exercises. How to prevent pelvic floor hypotonicity by avoiding excessive body weight gain, performing pelvic floor strengthening exercise, use of pelvic floor toners. This patient can do at home also. EMG biofeedback, electrical stimulation associated with biofeedback give wonderful results. Exercises, not only the pelvic floor strengthening, but the core exercises, that is abdominal and the pilates. So why there is delay in diagnosis? Underreported by patient, delays seek for help as it is not life-threatening. Many patients suffer in silence. Too embarrassed, consider it as a normal part of delivery, or aging, lack of awareness regarding treatment options available for pelvic floor dysfunction. So pelvic floor strengthening exercises, it restore muscle tone, strengthen the pubococcygis, should prevent or reduce pelvic floor problems. Pelvic floor muscle tone is the strengthening is the first line conservative management for women with stress, urge, mixed or urinary incontinence. Benefit greater in younger women with SUI alone. So this is a nice draft guidelines for pelvic floor dysfunction. It says that prevention and non-surgical management of pelvic floor dysfunction in adolescent and women at as age of 12 years should be started. Adolescent and women should be encouraged to do pelvic floor muscle training to help prevent the symptoms and signs of pelvic floor dysfunction. Pregnant women should be offered a 3-month program supervised pelvic floor muscle training to help prevent pelvic floor dysfunction from 20 weeks of pregnancy. If any prolapse, as it is documented by literature also, there is inheritance, like if it's to the mother or sister, then there is a tendency that you may also have a prolapse. So if that's the patient is having the history, it should be started more earlier. Program, pelvic floor muscle training program should be started more earlier in her. So improving women's awareness of pelvic floor health and encouraging them to practice pelvic floor muscle exercise throughout their lives is the most effective way to prevent pelvic floor dysfunction. Draft guidelines recommend that adolescents 12 to 17 years of age should be taught pelvic floor anatomy, pelvic floor muscle exercise as a part of school curriculum, and women should be advised that exercise and a balanced diet can help prevent pelvic floor dysfunction. So to have a good sexual function, it's necessary to prevent pelvic floor dysfunction, and that we need to identify whether it is underactive, it's overactive, or it has both the components to see that. So management, it's as for pre-operative, operative cases of pelvic floor dysfunction, you need to do a pre-operative patient counseling, that what is her approach, what she want, sexual activities because of the condition, prolapse, endometriosis, whatever. Cross-disciplinary approach, you need to involve with other specialty you should. And pre-operative optimization, as all the metabolic syndromes or weight gain, diabetes, hypertensive, whatever drugs if she's using that you need to optimize for better result. In this management, I would add 2 things. I don't know if it's a part of this or not, but when we're discussing it, laser has a wonderful role in GSM at least. Means as a urogyne, I'm using laser also. But in GSM, when we all know that we use estrogen left and right, but after even using estrogen, many patient still has this complaint of GSM. That is then And I think in chat box somebody has asked role of testosterone. So testosterone, yes, from the premenopausal in reproductive ages also you can use, till you can even use in postmenopausal. But in earlier we refrain, means that is something that is last drug of choice to use, because if we use in early, then the chances of hair growth and that is up because she's too young. But yes, postmenopausal or perimenopausal it can be used very nicely and it has wonderful result. Pelvic floor dysfunction, though not life-threatening, but life quality worsening is definitely there. And the female who is asking for it should be definitely given the options, that there are options to be treated. So these are my references. Thank you.
Thank you, Dr. Mohini. That was indeed quite an elaborate and exhaustive and informative talk. And we are really, really grateful to you for having us over here. And I request our chairpersons, Dr. Prerna Sehgal, and I'm emotionally also touched by the similarity of the name.
Name, yeah. We share the
And,
same
uh,
name, yeah. So
and
it was an elaborate talk by Dr. Mohini. Being a Eurogyne, she touched all the aspects and she gave, she threw light on each and every aspect of pelvic floor dysfunction. The irony with India is we have become the fourth largest economy, but talking about sex is still a taboo here. So, Dr. Nishi rightly said, we need to be proactive in taking history, and we need to release inhibition from the patient. We have to be tactful so that the way we approach our patients, we make them so comfortable that they come out with their problems. Because pelvic floor dysfunction is bound to affect the sexual function. And a woman who has a satisfying sex life is generally very well adjusted in life. She is able to handle the challenges better than others. So it is, a satisfying sex life is no more a luxury, it is a necessity. So we need to, the speaker rightly said, there has to be an integrated approach. I'm in medical care, physical therapy, and psychological support. All the three have to be offered to the patient. Thank you.
thank you, ma'am. We have Dr. Ginny with us. Ma'am,
Yes,
you are
ma'am,
ready.
I very wonderful lecture. And I just want to congratulate ma'am Prerna, it was. And it is a wonderful point which she pointed out, that stimulated orgasm to for bettering the pelvic muscle tone. This is wonderful and we need to talk about it. And I also wanted to confirm again that in postmenopausal, I think Kavita ma'am is here. She's our professor from CMC, that testosterone patches are being used in USA and in even Europe because they are approved. Even the latest ESHRE guidelines have approved them even for the premature menopause, because if the serum levels have to be done and they are given for hypoactive sexual disorder desire in menopausal, whether menopausal or premature menopause. There is a general point which I wanted to mention, that whenever we talk about sexual problems or a woman coming to us with any issue, whether it is a arousal, desire, or some organic problem like prolapse or SUI, which is leading to a dyspareunia, GSM of menopause, where is the partner? We need the partners there, and we must have a partner with partner session. I am married for 30 years. I am going to celebrate my pearl anniversary soon. And I will tell you that in the first 2 years, I wanted help. And my partner, who is also a doctor, we are mature enough to talk about it now, he told me that there is no such need as needing help. So the awareness of the partner to the problem of sexual unfulfillment in the woman has to be made aware to men. Like we have awareness drives for cervical cancer, everybody knows there is an HPV vaccine. Men should know that women are just not slam bam, thank you ma'am. They need more arousal. They have a detailed sexual requirement. And in menopause, the problem we face in Punjab is the menopausal age is advanced to 50 plus. Women are active and men are becoming obese. They are binging drinking, and they are losing potency because of so much of obesity, metabolic syndrome. So we have active women who need in regular sex and they are not getting it. So apart from desire, it is the other way around. We need a partner's counseling, that a regular sexual life, even in menopause, is important for our pelvic floor health.
Yes, thank
I
you,
think this
ma'am.
is a beautiful
Thank
concept
you for
that the
this.
second speaker has given.
Thank you for that wonderful and eye-opening input. Really, really happy to hear
The
that.
partners should be there. Why are they
Yes,
not there?
very much, very much. Such a valuable input, ma'am. Thank you, Dr. Guinea. Thank you, Dr. Sangeeta, ma'am. And thank you, Dr. Prin. Dr. Sangeeta is there with us. We can't see her logged in. So we can move on to our next session with this. Thank
Just
you.
1 minute. I just want to say, ma'am, patches, I don't know testosterone is available or not. Gel is available. Transdermal testosterone gel is
Some NRI patients were showing us. That is why me and my colleague.
Ma'am,
we
it's
found
available in
that,
Bhatinda also. You will get
Okay,
there.
wow.
Yes, it's available, freely available. Means,
Okay.
means any company, I'll not name it like in this message. So many companies are there, but yes, means they have one matlab expire
It's
ho jaye, so
approved by the IMS, the International Menopause, the ASHRI, ASRM guidelines of 2024.
And ma'am,
I recently
again,
prepared a write-up and it is approved.
and 3 months back only, again from USA, when there has been released that HRT as the menopause problem they are facing. So they are again restricting or
Hypoallergenic
limiting
sexual disorder.
HRT. They are means promoting using of HRT in menopause.
Yes, yes.
Thank you,
Testosterone
Dr.
levels
Mohini.
need to be done so that you don't exceed the premenopausal levels.
Brilliant, valuable inputs and such esteemed interactive session. Quite an informative one, and I hope all viewers have enjoyed this. And thank you, Dr. Mohini, ma'am, Dr. Prerna Sehgal, ma'am, Dr. Guinea, ma'am, and Dr. Sangeeta, ma'am, for your kind presence. And we look now forward to the next session, and that will be a panel discussion that will be moderated by myself and Dr. Madan. Dr. Madan, have you logged in?
Yeah. Thank you, Dr. Mohini ma'am, Guinea ma'am, for your kind inputs. Thank you. Is Dr. Apurva there? Yeah. Sure. Okay. Yeah, we are starting the panel, and we have got eminent experts, Dr. Apurva Datta, who is the chairperson of Foxy Sexual Health Committee, and respected Dr. Neelam Sodhi, ma'am, who is the senior obstetrician gynecologist at Ludhiana. I think ma'am is not joined, and we have got the eminent panelists for this panel, Dr. Mohini Agarwal, madam, from Bhatinda. Just now, madam has been introduced. Dr. Jeannie Gurn, who is the senior consultant obstetrics gynecologist, urogynecologist from Ludhiana. Welcome, ma'am. Next. Dr. Renu Gupta, ma'am, who is the director and chief consultant at Reno Hospital, Ludhiana, who is the treasurer of Ludhiana OBGYN Society. Welcome, ma'am. Next.
Thank you.
Dr. Meenakshi Rohila, ma'am, who is the secretary of Chandigarh OBGYN Society, Northern India. I think ma'am has not joined due to some emergencies. Thank you. Next. Dr. Tapasya Dhar, ma'am, who is the professor, Department of OBGYN at CMT, Ludhiana. She is such a senior obstetrician gynecologist. Welcome, ma'am. Thank you for joining. Next. Yes, Dr. Nishi Garg, ma'am, who is the secretary of Kotakpura OBGYN Society. Yeah, welcome, ma'am. I welcome my co-convener and co-moderator, Dr. Prerna Keshan. Just I will share the screen now. Is it visible? Full screen?
Not yet, Dr. Kamble. Yeah, now it is.
No, okay. Yeah, as we are discussing since 1.5 hour, what are the sexual dysfunctions, how it happens, which are the predisposing factors, how it goes, what are the treatments. Actually, Kavita Bhatti ma'am has covered this topic very well. We will not waste much time into the theory because we have already seen, but we will more focus on the practical aspect, that is clinical cases. Yeah, everyone knows what is sexual health. Just I will take in short. It is the state of physical, emotional, mental, and social well-being in relation to sexuality, and it is not merely the absence of disease, dysfunction, or infirmity. There are two models for this sexual response cycle. First, we have to learn the sexual response cycle. The oldest and most commonly followed model is the uh, Master and Johnson's model. This is the linear model, which contains the phases of excitement, plateau, orgasm, resolution. There is one another model, which is the Basson's model, which is also called a circular model. And the main base is the intimacy. This is intimacy-based model. As emotional intimacy gives the sexual stimuli gives sexual arousal, and this arousal and desire gives the emotional and physical satisfaction, and this circle goes on. That is why it is called a circular model. As I have stated, there are four events, main events. First is the excitement, then plateau, orgasm, and resolution. Yes. Let us go into some discussion. What is the female sexual dysfunction?
So any
How,
lady,
how we can define?
yeah,
Yes, ma'am.
any lady who has basically a persistent problem in any of these four phases that you described, either arousal or plateau or orgasm, and the lady should actually feel that it is affecting her relationship with her partner, and she's actually distressed or frustrated about it. So generally these patients will come to us with these complaints.
Yes, as there are four main domains, that sexual desire, orgasm, and pain also, sexual pain. Whenever there is, as you have rightly stated, at any level, if there is any problem that can cause the sexual dysfunction. Then there are old classification also and latest classification. Old classification is DSM-4 criteria. DSM is Diagnostic and Statistical Manual. Um, there is some difference. Yes, anyone can take this. What is the change as per according to the DSM-5 criteria in 2013? Yeah. Okay. In the old classification, it was classified in main four, that female hypoactive sexual desire disorder, female arousal disorder, and female orgasmic disorder, and last is the pain, that is the dyspareunia and vaginismus. But as per the DSM-5 criteria, this interest, that is desire disorder and arousal disorder, these are the club together to form the female sexual interest arousal disorder. And female orgasmic disorder is continued. And last is the dyspareunia and vaginismus. These are the sexual pain disorders which are clubbed together to form under a single umbrella, that is the genitopelvic pain penetration disorder. This is followed currently. Then what are the effects of sexual dysfunction on either on a couple or on individual basis? Yes, Nishi ma'am, can you?
Obviously,
Yes,
Let
anyone can.
continue, please. Zini, you
no,
continue.
it's as, yeah. So it's just basically a person feels depressed, they feel frustrated, they will have low self-esteem, whether it is a man or a woman. And of course, it can lead to anxiety, depression. They can affect their interpersonal relationships. So they can be domestic violence, and it may go up to as far as separation or divorce. And for the men, it may even mean performing less well, premature ejaculation, or even erectile dysfunctions. So all these can happen because of the sexual dysfunctions.
Yes, that means mainly it is causing the psychological problems, and which is definitely going to disturb the interpersonal relationship, and that is going to affect on the sexual function. Anyone want to add something? Nishi ma'am, do you want to say anything?
Basically, this is going to cause psychological problems because patients don't open up. Actually, they should discuss amongst themselves whatever is the problem. And once the discussion is not there, it causes marital disharmony and psychological symptoms, irritability, restlessness, all these symptoms. Patients do come to us with this fatigue, frustration, anger. But when you go deep into the history, then you come out with the actual cause that they are having this sexual disorder.
Yes, very true. Actually, we need to put sexual history in
Yes.
our daily work, which we are not doing. We are taking their obstetric history, medical history, but sexual
Yeah, yeah.
history is a very important part. And unless we ask, they will not come out. I have seen patients not come out for the initial 4 or 5 times. And then when you keep on persistently asking them, then only they come out. And there can be multiple small issues which actually is causing so much disharmony at home that they are so unhappy, they are anxious, they get frustrated, their quality of life gets affected by all these issues.
And one important aspect problem happening is due to this chronic female sexual dysfunction that is going to affect the male partner.
Yes.
Yeah, that is the worrisome part, and he may have premature ejaculation, erectile dysfunction, and that is the that aspect should also be addressed well. Uh, Prerna, you can continue.
Yes. Yeah. Thank you, Dr. Madan. And I welcome all our esteemed panelists, Dr. Jeannie, Dr. Renu, Dr. Tapasya, Dr. Nishi, Dr. Mohini, and Dr. Meenakshi for this wonderful esteemed panel. And as we are heading towards this particular psychosexual issues, we need to first understand how to counsel these clients. So anyone can take a little bit about the sexual counseling and its purpose for these particular patients, Dr. Tapasya?
Yeah, sure. So sexual counseling, you need to actually go into a detail in their history, like what is the problem that they are suffering from, exactly what are the issues, and then you need to guide them. So you need to basically develop a rapport with the patient. They should be able to tell you what are their desires, what are their myths that they are having, and whether there has been any childhood trauma or childhood history. All these things we need to actually go in detail and ask them what is affecting their way of thinking. And then you
Yes.
need to guide them, you need to educate them what is normal, what is abnormal, what is the need of the partner. And I believe when you're doing counseling, you should also have the partner along with
Yes.
them, so that you are able to educate them together, and both of them can put in their needs, and actually you can counsel them and teach them what are the actual things. And while you're doing it, you need to make sure that you speak to them very nicely, and you tell them that it is going to remain confidential, and you need to
Mhm.
support them in whatever decisions that they take. And it is not a single process, you need to call them repeatedly, and you need to
Yes.
talk them about it, you need to emphasize certain points. So this is generally what we do in our sexual counseling sessions.
Very well taken. Very well taken. And
Can I
this is
add
something.
something to it?
Yes, 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 ma'am. Yes.
In counseling, I think two part like very important. What I do is first of all, we confirm what patient is trying to tell. Usually in the sexual problem, patient bolta kuch hai and hota kuch hai. For an example, patient come with the looseness of vagina. She may have vaginal laxity and loss of orgasm both, which may coexist together, or she may have only loss of orgasm. So you need to reconfirm in the patient language, yes, this is the way she's talking, or she's talking about this person. Second, you need to explain the anatomy very well, what it is, where her the problem is, what she's feeling loose. Sometimes the patient think ki, she says like, I got a patient that niche ki jagah loose hai, but when I'm exam, I'm not feeling anything that it is there is laxity. And what she was saying, her labia minora were too big, means it were flower, means were quite long and it was rubbing. So she was like that is part is loose, but it has grown after delivery, or there has changes has occurred in labia minora. So she was like, that is for her, that labia minora was a concern. So we need to explain the anatomy also very well. And counseling, obviously, once you need to consult the patient, your husband separately, and then both together need to be consulted together also.
Yes, yes, very rightly said. And definitely, these are some unspoken problems of the females. We need to dig in and find out. They might not come with a leading answer, but we need to ask leading questions that has to be answered, because these are unspoken issues which they really do not come with as a complaint. Can we have the second slide? Yeah, so the brief office counseling based on using the helpful tools like Plicit. Dr. Apurva is here. Dr. Apurva. Dr. Madan, can we have the Plicit chart? So
Yes.
the Plicit model is about permission, limited information, specific suggestions, and intensive therapy. And this is a stepped approach specifically for general health care, as well as we need to understand that we have to take permission to talk about sex. We need to share the feelings, we need to be intimate, and we need to own all of your body, including genitals. You get to know your own body, to have your own set of likes and dislikes, and to enjoy sexuality in appropriate context. Dr. Madan, we can take the next information.
Yes. Limited information means we, as just Mohin Madam has said, we have to teach them the anatomy of the reproductive tract and give them the information about this, and how the this regarding the psychosexual education. And we have to also debunking the sexual myths that has to be addressed, and realistic expectations about the changing sexuality. This should be addressed, and what is the nature of the problem and what are the treatment options available. That information has to be given in this. And next, the specific suggestions means, if in any case, if we want to have some investigations or go further for the diagnosis and the treatment, we can give suggestions. For example, the laboratory investigations are there, or any other ultrasound, or any other investigations. We can go ahead and we can suggest them to, and also validate their complaints. That is very important in this case. And intense therapy means which are the treatment options available. And if in case we require a referral, for example, opinion of a psychiatrist or psychologist, we can refer that patient or take an opinion from the specialist in that purpose or in that case. And that is called intense therapy. These are also two other models, but the Plicit model is very commonly followed. In psychosocial therapy, there is sensate focus and cognitive behavioral therapy. These are the very important and commonly used psychosocial treatments. Sensate focus, anyone wants to comment on this? In short comment, what is sensate focus? Any of the panelists?
Yes, it's basically non-demand sexual touching. So basically, it can be simply as, lying down together or hugging each other, or just sitting together talking about good memories or about good things. And then slowly, once they do that, they get into the idea that they are together, and then, the sexual activity can start after that, or the sexual touch can start after that.
Yeah, basically, the aim of this is to reduce the anxiety, and start slowly with small touches and not directly indulge into the sexual activity. And the improvement in the sexual communication between the partners, which is definitely going to increase the intimacy between them, and which will gradually introduce the sexual activity slowly. That is the main motto of this sensate focus therapy. Communication is the key always between the partners. They have to openly express their feelings. What are their desires? What are their boundaries? This will facilitate the interpersonal relation or bonding in between them. And cognitive behavioral therapy is another mode. The main objective of this is to remove the negative thoughts or altering the negative thoughts which are preventing this sexual intimacy. To remove this negative thought, it is the main the objective of this. And this serves to change the sexual behavior by focusing on pleasure, not on sexual form. And this focuses on cognitive, emotional, and behavioral processes in the relationship. That is called cognitive behavior. This to change the behavior and start thinking from negative to positive thoughts. That is the main uh, objective behind this. Prerna, can you take this pharmacotherapy? I think most of
Yeah.
the
So
this thing has also been covered, but just we will go.
so it has been covered by Dr. Kavita ma'am quite in long and elaborately. And would like to hear from a panelist any pharmacotherapy you'll suggest for your clients or something that can help them with pills. Dr.
Yeah,
Nishi, Dr. Mohini.
Yeah, there are a number of medications which have been approved and can be used. So just as your slide is mentioning, testosterone, and as Dr. Mohini also said, testosterone gel patches are not available here. Buspirone can be there, DHEA, which is now not available in the standard 100 mg dose, but now we can easily get it at 25 mg dose 3 times a day. In certain situations like sildenafil, it's quite useful. Obviously, we know sildenafil has been used in men quite a lot, and flibanserin and of course bremelanotide. So these can be used, but the easily available ones are the testosterone gel. And I would like to add that in male premature ejaculation, there is a role of fluoxetine, and that can be used as well. So fluoxetine can be used in male erectile dysfunction, and that has been improved. Generally, in perimenopausal women where you have low moods, so again, fluoxetine has been approved for women in perimenopausal and postmenopausal age to deal with the mood symptoms of perimenopause. So that's another drug I would like to add to the list which you've already mentioned.
Yes, ma'am. So we all know SSRIs and SNRIs are widely used for all these issues in our day-to-day practice, and we have not heard of late from Dr. Reenu and Dr. Meenakshi. Do you want to add on to
There was a
what
drug
Dr.
which
Jean?
increases. There was a drug which increases nitric oxide, like L-arginine sachet. I was reading. So
Yes,
that
sir.
many years back there was an ointment available for that, but now later on it was withdrawn.
No,
So
it is currently also available. L-arginine cream.
yeah,
Yes.
that was very
Dr.
It is having a good result actually by
Yes.
applying a small quantity on clitoris.
yes.
It gives good results. And of course, L-arginine sachet can be used or tablets can be used. These are also available. And DHEA, which is easily available, we can use it. Sildenafil, we all are using in gynae, in infertility also.
Yes.
Yes.
And
Let us
my one question: these drugs are available in Bombay or not? This flibanserin and second one.
No, flibanserin is available in India currently,
Yeah,
but it is costly drug, but
okay.
not available everywhere. But routinely available are the testosterone, DHEA, sildenafil. These are available. Even buspirone is also available. But flibanserin is currently made available in India.
So first line, we should give testosterone gels then?
Not testosterone, but we can try with this DHEA, sildenafil also. Testosterone is also available, but in selective cases.
Okay.
Yeah, but we have to be cautious about the use of these androgens.
One out of the track compliment I would like to give to Dr. Janie, that beautiful flower on that on the hair in her CV slide. There's something very enigmatic, very nicely put there. Thank you, Dr. Janie, Dr. Tapasya, and Dr. Nishi.
Thank you, ma'am.
Yeah.
That is pretty beautiful. I couldn't help but comment.
Thank you.
Yeah.
So, Dr. Madan, you can move on to the female orgasmic disorders.
Yeah. Now, next common dysfunction is the female orgasmic disorder. Then, what is this female orgasmic disorder? Many times women experience this, but don't come up as we are discussing. Uh, then,
So
how to
whenever
define? Just how to define this orgasmic disorder?
when
Like,
there is a change in the frequency or intensity or the timing and the pleasure they get, whether there is no pleasure or less pleasure in the timing of orgasm, and it should last for at least 6 months, then you can call it a female orgasm disorder.
Yes, you are very right. Any female sexual dysfunction symptoms should last at least more than 6 months. And second thing, it should significantly disturb the interpersonal relationship.
Yes.
Disturb interpersonal relationship. That these are the criteria to define any sexual dysfunction. Then there are types of this thing: primary, secondary, situational, and general. And primary means women have never been able to have orgasm. And secondary anorgasmia means women have previously been able to have an orgasm, but currently there is problem in experiencing orgasm. And situational means it occurs. The orgasm occurs only during some specific situations like oral sex or masturbation. That is called a situational. And generalized anorgasmia means there is inability to achieve the orgasm in any situation or with any partner. Okay. The next question is how to evaluate such case. If any case comes in our OPD, she is not feeling or experiencing orgasm, how to go ahead? Yes, anyone. This is a practical
I
question.
think, first of all, of course, you will have to take the history, why they're coming. And I think you have to read their body languages. And I think sometimes if they're having interpersonal conflict, it might be better to take the history and to evaluate them separately also. That's very important. Because many a times, the difference, the problem with having being sexually intimate has led to disharmony between them. So once you've taken the history, of course, the next thing you actually have to ask the woman whether she's actually ever had an orgasm and what does it feel like. Because surprisingly, many women don't even sometimes know. I have had young girls in my clinic who don't even know about their private parts and what is what and how you can actually achieve an orgasm. Then third, of course, physical examination. And there are certain sometimes hormonal disorders, and it's a very big problem actually, an orgasmia, because I think there's number of conditions which can also lead to an orgasmia, and it's just not a psychological thing. So medical issues also, certain drugs also can decrease libido and an orgasmia, and a psychiatric evaluation, as is mentioned on your slide, is very important because patient may be having some psychological disorder, and that may be unmasked by the evaluation of the patient.
Yes, ma'am. You have correctly said. Uh, Basically, everything comes again with the sexual history, and main part is almost covered there. Taking the detailed sexual history from both the partners is mandatory, very much necessary. Then physical examination for any physical problem, any anatomical defects that we have to see, and as per the case. Necessity, we can go ahead with the laboratory investigation. And as and when needed, psychiatric evaluation is very much needed. Then how to manage such a case of female orgasmic dysfunction? We will not go into the detail because we have just seen the psychotherapies. Just we will have a look on which therapies are available. For example, sex counseling is there, supportive psychotherapy is there, marital therapy, behavior modification therapy. Mainly these things are done by the psychiatrist or psychologist. What we can do at our level, we can have clitoral devices also, so vibrators, dildos that can be used, or many women are using that, or we can advise them, and pharmacotherapy. Yeah. One of the psychotherapy, that is the directed masturbation. Directed masturbation training is there, which is largely a behavioral technique, and it is conducted as a weekly sessions, and for up to 4 to 16 weeks. That involves a graded exposure to genital stimulation with the use of any sexual fantasy or the vibrators, and which is used to facilitate the heightened arousal or orgasm. That is the directed masturbation. Anyone can highlight on these sexual enhancement devices?
There are a number of devices now available in the market which can be used by women, and so I've had patients in my clinic, and I've actually given them the link to these websites where they can procure these devices confidentially, and they can help with stimulation. I think first of all, they need to understand their anatomy, and once they're aware of their anatomy, then they need to also understand the difference between the clitoral and the vaginal orgasm.
Yeah.
And slowly they have to, and then they can get these devices. So there are vibrators, dildos, and there's so many other devices which are available in the market. Anything which has pulsations and which can actually excite the nerves is going to cause an orgasm. So, a number of safe devices now available on the market which may be used by women.
Yeah. Okay. Yes, we will have one or two cases for the discussion. Prerna, can you take the first case?
Yes, our panel is going quite interesting, and we have this first case, which is 33 years female accompanying with her husband. She is complaining of pain at the time of penetrative intercourse, and this is happening since last 8 years. Now, the husband is complaining of lack of libido since more than 6 months and unable to hold the erection for more than 2 to 3 minutes since then. So, anyone can take this. What are you thinking? What is going wrong in this case? And anybody, any comment on vaginismus and how to deal with this? What
So
about
I
the
think,
husband's problem? Yes, please.
yeah, I think the patient has vaginismus, and probably the husband is now losing interest, and probably he's having some amount of erectile dysfunction. For vaginismus, I think generally it is when a patient doesn't even allow entry of either the penis or any finger or any other object, although they want to actually undergo the whole process of sexual activity, but there is constant pain and they do not allow entry of anything.
There are various grades and types of
Yeah,
vaginismus that we have starting.
yeah.
Yes.
Yes.
That's what
So
I was going to say, that there are grades of, and while I think most important is to actually let the woman, so assess the woman. So I think so you have to grade the vaginismus, and yeah, grade 4 is when they are completely jump off the bed the moment you even touch the private parts. So I think, yeah, so vaginismus is one thing which is there, and of course now as partner is gradually losing interest and intimate with his wife anymore.
Yeah, so we once we grade it, we need to uh, let the female get some help, and these are lemon grading and the passive gradings. Can we have the next slide, please? So, how are you going to evaluate vaginismus, Dr. Mohini?
So for
Yeah, any
evaluation of vaginismus, means whenever I see a patient, means whenever patient comes to you, already she has visited to many of them people. She's already usually a diagnosed case. So in first visit, I never examine her to very sure. And when I land, I always propped up her head end and I try to see the face. I never touch it, means PSPV is not done. Just take a swab stick and just do a vulval mapping. If she's tolerant to that, if she's comfortable, then go step by step forward and see whether she's doing relaxation, because the patient is very anxious. She has already been to many places, she's already diagnosed, she will not come with one day history. She has usually a long files and everything. So just go very, take a swab test, just see how the sensation, pain, and see whether she is able to relax. There are many relaxation exercises. try to calm her down, and then proceed it.
Yes, yes. There's a very important word in this slide that is sex is sinful. These females somewhere have this mental makeup, so we need to just assess that her religious and her cultural backgrounds and her concepts and her beliefs and all that she has experienced in her near future, as well as her domestic and social reasons for not for having such a dreadful
Yeah. So,
sexual pleasure. Yeah, yeah.
I think that is one of the most common things which I talk to women about, that they think that sex is wrong. And many a times I have gone as far as telling them that you are here because your parents had sex. So, it cannot be wrong. The whole society exists because of that. But that is because it's a big taboo, even in the school when they're actually giving sex education. They just run through the pages of the book without actually talking to the children. And then they end up getting wrong information from all the children these days. Anyway, have so much access to online stuff. So see, I always tell someone that, if I knew about sex at the age of 15, my child will know that at least 3 or 4 years earlier nowadays, because there is so much this exposure to the media. So our job should be to guide the children. So one is, of course, a taboo, and the second, more important, is it's sexual history of sexual assault, where people are not very happy coming forth with. So I think if the vaginismus is severe, the first thing I have to always think about is getting a psychologist to see this patient to actually get to the root of the problem. Because structurally, most of the times we will never find anything wrong. It has to be the psychological thing. And I've had patients who have not been sexually intimate and have come to my clinic requesting an IUI procedure just because they have not been able to have a child because they've not been. And I've counseled her, and then on they've gone on to have children. But it's, I think, so two things. I think vaginismus, whenever comes to my clinic, I'm always wanting a psychological evaluation of these patients to get to the root of what the problem is.
Yes, ma'am. And a lot of stress and work-related pressures
Yes.
nowadays affecting our
Also,
sleep patterns
sometimes,
also we need to evaluate.
yes. Also, sometimes the what the peers say or what the family says will also affect. So, I had a patient with vaginismus, and her sister actually got a postcoital tear on the first day of marriage, and that really affected her mentally. And so, she was so scared to even initiate any sexual activity because she thought she's going to land up in the hospital the first night itself. So, she just did not allow her husband to even touch her or do anything. So, till you actually go in detail, it can be so varied, the causes actually, why they are doing, why they are
Well,
not
so many
allowing.
things, yeah.
Uh,
So many things to actually take
This
in.
is
Yes,
actually
yes.
a very common scenario. That is why we have to ask the details of sexual history of sexual abuse in the past.
Yes.
All of us have, I think, encountered the patients of this vaginismus. This is very,
Yeah.
very common.
Yes.
Very
In
Very
case
common.
of
common.
in this
And like
vaginismus case,
newly married couples, when they come to us, I just gave
yes.
them Xylocaine ointment treatment, which you have mentioned,
But
right?
asking the sexual history in detail is very important, and
Very
the
important.
counseling has a great role in the management of these cases.
Yes. You can go to the next case, maybe.
Yeah, treatment of vaginismus. Treatment of vaginismus. Yeah, as you have said, the first is the address the medical condition and assure that the treatment options are available. Assurance is very important. Then we can give the symptomatic treatment first. That is, as you have said, the lubricants and anesthetic creams play a great role. And sex education is very important. Counseling is very important. Then next treatment part is the systematic vaginal desensitization with use of dilators. That is also an effective therapy. Then pharmacotherapy, psychotherapy, cognitive. These are the behavioral treatments available. Sensate focus, and lastly, the recent advances means injection of Botox. This use of dilators for the desensitization. The dilators are available in the increasing numbers. These are some plastic, silicone, or glass materials are available. And progressive dilators are very helpful to stretch the vagina and allow the woman to become comfortable with the vaginal penetration slowly. Yeah, anyone wants to comment on this Botox treatment management, how it is useful? Yeah. Any of the
So
panelists?
yeah, in severe vaginismus, when patients have tried everything and you find that there is no sort of a psychological problem, I think if it is just the fear of penetration, then of course Botox, which acts as a neurotoxin and blocks the nerves, it may be injected in the vestibular area and around the bulbospongiosus muscle so that the patient's nerves get desensitized. It's only the lower third of vagina which is a problem. So I would then recommend that possibly that patient can then have it and try it and give it as an option. So once they start doing it on and the effect of botulinum toxin will last for some time. It's not just that it will happen. So by that time, probably they become more intimate by the time it wears off in 6 to 9 months. And then it becomes easy for them to be intimate.
Yeah. Okay. Yes, welcome, Apurva. Uh, Another case is there. A 52 years female, which is para 2, both full-term normal deliveries, and she is complaining of laxity while having penetrative sexual intercourse. Also, she is complaining of passing of urine while sneezing, coughing, laughing, or while working, and she is unable to work for long hours. Also, there is some skin tag bothering while having the penetrative sex. Then, what is the diagnosis? What you think? What is the diagnosis? Apurva, can you take this?
Hello. Yeah, I think the panelists are there. So I can, yes. So, yeah, when we are talking about, you are talking about the GSM. So, GSM is so common nowadays. So, it is what is the genitourinary symptoms of the menopause. So, it has a wide range of, symptoms. Symptoms may be the patients is coming like just today only I am seeing a patient and they're coming ki burning sensation. So, doctor साहब ऐसा लगता है कि जैसे जल रहा है. So the symptoms can be from a burning sensation or can be have a symptoms like the sexual dysfunction, can have a symptoms of the stress urinary incontinence, etc. So there is a wide spectrum of the symptoms are there in the genitourinary symptoms, and nowadays because the patients are so much aware of the things now, many times the patients are coming and they are saying कि I have a problem of the genitourinary symptoms. So when the patient is coming, you have all the, this will give you an opportunity to ask the other symptoms also. Like there might be the recurrent UTI, the patient might complain with the dyspareunia or might complain with the any things like that. So this is actually wide spectrum. And what I always used to say that when we are talking about the genitourinary symptoms of or any symptoms of the menopause, the first treatment is the love, tender, and care. This is very important to tell your patients. Your patients are menopause is not a disease. Definitely you have to be very important, and it really need the support from the partner, from the family members, from the kids, from the children. So this is very important. And lifestyle modification is absolutely very important. Give sometimes to give the counseling to your patients. This is very important. So these two things, and then after we have all the pharmacogenetical, pharmacotherapy, etc. is there. I think Madan sir will describe them. Yes, over to you, sir.
Yes, as far as the management is concerned, we already have discussed psychosocial therapies and the medication options are available. These are also being discussed. Moisturizers and lubricants, all we know, use of estrogens, androgens, tibolone, this can be tried. Local estrogen therapy, vaginal tablets are available, cream is available, vaginal ring is available. We know this Istioran, all these Premarin creams, this can be tried. The role of Tibolone, Tibolone is also available in the market in the doses of 1.25 to 2.5 mg per day. This can be tried. It has also the good results in perimenopausal patients. And role of osmemiphene, which is the SERM, it can be used as 60 mg daily orally. Again, there are few non-surgical treatments are available. Some surgical treatments are available under the umbrella of cosmetic gynecology, which are used for the functional purpose. I will not go into the details, but just I will mention some energy-based devices are also available, like radio frequency, laser, HIFU, HIFEM technology is available. Some minimally invasive procedures are available, like platelet-rich plasma, some fillers like hyaluronic acid, Botox, carboxytherapy, mesotherapy, etc. And surgical treatment parts like labiaplasty is available, monsplasty, pulporrhaphy, perineorrhaphy is available, clitoral surgeries are also available. These are the surgical parts. Will not go into the, or anyone wants to comment on this use of platelet-rich plasma for the vaginal
No
rejuvenation?
panelists have left, Dr. Madan. Only Dr. Tapasya is here.
Okay.
No, I'm here too.
Ginny
Yes.
ma'am is there.
No,
Are you
Dr.
using,
Ginny.
ma'am, PRP? Are you
Yeah,
using
PRP
PRP?
I'm using, yes. PRP
Yeah.
I'm using, especially in very, very atrophic women who are still sexually active, and if normal Evelon and everything's not worked, then yes. And you know what? I think people underestimate how much it's not only the vaginal function, even your bladder function really gets affected after menopause. Because if you look at the embryological origins of your bladder, so the vagina and the part of the bladder share the same embryological origin. So giving treatment vaginally with PRP or with lasers is quite useful for both, and definitely it can improve the sexual function and dryness.
Yes, absolutely right, ma'am. So we are at the end of the session. Yes. Yes, vulvodynia is also there, vestibulodynia. We are not going to discuss this today. Yes, almost. Yeah, it was a fantastic panel, and we all have enjoyed from all the panelists.
Thank you very much.
Thank you
Yeah,
so
thank
No,
you
much.
so
it's
much.
we've learned a lot new things. We also always learn whenever everybody shares. So thank you very much for inviting us to be panelists on this session. And I wish you both best of luck in your forthcoming elections and all the very best.
Thank you so much, ma'am.
Wishing you really best of luck, all the best, and thank you for
Thank you,
making
ma'am.
us part of this wonderful discussion. Actually, we sat and read a bit about it.
Yes,
Otherwise, in our practice, we
absolutely.
don't get to read so much of about sexual
Yeah,
medicine.
absolutely.
But
Absolutely.
we could see all sexual medicine experts today.
Yes, true.
So much of valuable inputs and so much of experience and so much of such a long way you have taken this panel. It's really nice.
Yeah, Ginny ma'am has actually give good inputs.
Thank you
Thank
so
you. Thank you so
much.
much, Tapashna ma'am. Thank you so much,
Thank you.
Jenny ma'am.
Yeah,
Thank you.
All right. So nice connecting with you all, and
yeah, nice
have a
connecting
good evening.
with
Yeah,
all
have a good
societies.
evening.
Yes.
Yeah.
Thank you,
Happy
Apuba.
Yeah, yeah. Thank you, and sorry. Yeah.
Thank you all the